everyone, and welcome to the Surgical Ergonomics podcast, where we will be discussing everything related to surgical and procedural ergonomics, the people, ideas, and technology that will help enhance your physical wellness and career longevity. I am your host, Geeta Lal. I am an endocrine surgeon, speaker, consultant, and surgical ergonomics coach. Having experienced work-related musculoskeletal issues myself, I am committed to increasing awareness of and developing solutions to counteract the impact of poor ergonomics on the professional and personal lives of healthcare workers in procedural areas. This episode of the Surgical Ergonomics podcast is sponsored by NextSpine. As surgeons, we spend years learning how to position our patients, our instruments, and our operating rooms, but we often pay far less attention to what happens to our own bodies during surgery. This isn't just about getting through a particularly long case. The physical demands of surgery can accumulate case after case, day after day, over an entire career. NextSpine is a lightweight, wearable support system designed specifically for surgeons and proceduralists. It helps support the head and neck during forward-leaning surgical postures by transferring some of that physical demand away from the cervical spine and into the torso. Overall, it weighs less than 2 pounds and is worn underneath the surgical gown or leads and is designed to move with you without changing the way you operate. NextSpine has been evaluated in the OR with published research demonstrating improvements in posture, reductions in muscle activity and discomfort, and high usability among surgeons. If you'd like to experience NextSpine for yourself, you can schedule a trial and learn more through the link in the show notes. NextSpine is also offering a special purchase price exclusively for listeners of the Surgical Ergonomics podcast. NextSpine, because protecting your ability to operate is part of protecting your career. Hi, everyone, and welcome to another episode of the Surgical Ergonomics podcast. In today's episode, I'm delighted to welcome Dr. Fahad Alam. Dr. Alam is an associate professor, anesthesiologist, and medical education researcher at Sunnybrook Health Sciences Centre and the University of Toronto. He is also a hyperbaric medicine physician at Restore Hyperbaric Oxygen and Medical Centre. He holds a Master of Health Science degree focused on advancing medical education and knowledge translation. Dr. Alam is also the current medical and research director of the Sunnybrook Canadian Simulation Centre and serves nationally as the chair of the Canadian Anesthesiologist Society Simulation and Education Section and chair of the Continuing Professional Development Committee. He also co-created Chisel, a virtual and augmented reality innovation lab, and leads its satellite VR/AR learning and clinical applications mobile lab at Sunnybrook Health Sciences Centre. As if all that wasn't enough, he has developed a focused program of clinical ergonomics and surgical ergonomics research, working at the intersection of human factors, clinician performance, and patient safety. He has served in leadership roles within the Society of Surgical Ergonomics, contributing to advancing ergonomics-informed clinical practice, education, and research internationally. Hello, Fahad, and welcome to today's podcast episode.
Hello, thanks for having me. I'm very excited to be here.
Of course. So, Fahad, just to get us started, would you be so kind as to share a little bit about your background, including where you grew up and how you arrived at your current role?
Sure, no problem. So, like you said, my name is Fahad Alam. I'm an anesthesiologist at the University of Toronto, and I grew up in Toronto, Canada, specifically Etobicoke and Mississauga. I am currently a father of three rambunctious kids, 12, 10, and 7, which take up most of my time in addition to my career, my clinical responsibilities. But my training background is I went through medical school at McMaster University and then did my residency at University of Toronto, where I also did my fellowship at the Wilson Center for Research in Medical Education and Advanced Education Research and Curriculum Design, and then did a knowledge translation master's looking at medical education. And from there, I was working at Sunnybrook Health Sciences, which is a large trauma center in Canada and academic center as well. So I started focusing on medical education, specifically curriculum design, pedagogy around why human behavior and human factors, the why we do what we do, how we teach, why we learn, and then just kind of spread out to then my clinical load turned into a little bit more hyperbaric medicine as well. And now I do research around all of that. And ergonomics work started about, I guess now almost 4 or 5 years ago, and I haven't looked back. I love it a lot, and I think it's a very understudied and under appreciated field, as you know, and that by a lot of the systems that we deal with. So I'm glad I'm working in it with some great people like yourself.
Oh, wonderful. Thank you for sharing that, Fahad. It's interesting. The ergonomics work clearly, nicely dovetailed to all the work you were already doing around human factors and teaching, etc. So that's great to hear. For our listeners, I'll point out that, I was introduced to Fahad through Dr. Julia Lay. She's a hepatobiliary surgeon at Sunnybrook Hospital at the University of Toronto. And that's how Dr. Alam became involved in the Society of Surgical Ergonomics, and I've had the pleasure of listening to him talk about team ergonomics and dynamics at various sessions. So, Fahad, with this background, could you share with our listeners some of the work that you have been doing in procedural and surgical ergonomics? Perhaps we should start specifically with kind of, what the rates of injury are among anesthesia providers and how sort of, the team dynamics come into play in looking at these injuries, etc.
Sure, no problem. It's something, as an anesthesiologist, you're always kind of thinking about physical constraints, positions for long periods, managing high acuity situations. And then, I was in the OR and it's always in the back of your head, but it's never been, no one has prompted it to come to the forefront. And that's not just in anesthesia, that's in the whole team. So
Hmm.
you start noticing that how much strain there actually is, and not just physically, but also cognitively across yourself, from yourself and across the team. So that's when interestingly enough, you mentioned Dr. Hallet. I was actually working in the OR with her one day, like a few years back, and I looked at her and she was standing on a fatigue mat.
Hmm.
And I looked
Hmm.
and I said, I have those in my kitchen. I use that when I'm standing there washing dishes or cooking food. And why do you have that here? And she was obviously and is still a huge champion of ergonomics. And we just started to talk about ergonomics as a whole and how common these challenges are. And these are like there's very little formal training around or system design thinking, addressing it. And it's almost just accepted as part of the job. And I started asking, well, like you're saying, well, what are the rates in anesthesia? What are the rates in surgery? Like, what do we really even know? And we know that poor ergonomics contributes to physical fatigue and cognitive overload, but it can affect decision making, technical performance, and in environments like the operating room, even small decreases in performance can have significant consequences. So ergonomics plays a direct role in maintaining patient safety and consistency. So, she said, okay, you got to get involved with the Society of Surgical Ergonomics. And that's where I met amazing people like yourself and the team and got involved quite a bit. And it was just so exciting because it was a new area of work that we could have, that was not a new topic, but a new spotlight, I like to say. And that's what really drove me to explore more seriously. So I started looking into our own data, and the literature says there's anywhere between 39 to 89% prevalence of potential work-related musculoskeletal injuries in the OR, whether it be anesthesia, surgery, nursing, allied
Hmm.
health, PSPs, that type of thing. And I was like, that's a wide range, but it's not an insignificant number. That's a
Right.
huge number, right?
Hmm.
Um, and that started getting me to go along down the road of, okay, well, what can we do? And I started talking to Julie a lot more. And, we started going on, as you know, we started going down the path of studying team ergonomics in the OR because when I went through all the literature, it was always about how does anesthesia help itself? How does
Hmm.
surgery help itself? How does nursing help itself? And at times when we're in the OR, I'm looking over the drapes, what they call the blood-brain barrier, right? Looking over
Yes,
the drapes and
yes.
thinking
Yeah.
and thinking, that's I can help the surgeon by positioning a table or reminding them that, hey, like you're bent over this way. Maybe you want to take a break. Maybe, you've been operating for 9 hours now. Do
Hmm.
you want someone to bring you a cup of water with a straw? Do you want to take a step back? Do you want to stretch? And I can have a say in that. and I can speak up. And we haven't really thought about how we can influence each other, right?
Right.
How can I help with like just, the way we set up the room? Was actually brought into by a consulting company because of my VR work. They were making new ORs in a new surgical building. They said, can you come in and as the anesthesiologist walk through these virtual ORs with me and tell me how ergonomically how to set that up? I was like, well, this is the first time I've been asked as an anesthesiologist, like, how do we set up these ORs? So why aren't we thinking about this before, right? So we started thinking about how can we look at team dynamics and how team members can influence each other inside the OR, and that's how, and I can go into it if you like, but that's how we start coming up with these North American wide study initiatives, and now hopefully knowledge transition or implementation initiatives looking at team ergonomics.
Right. Wow. So it's amazing how, just a conversation with your colleague in the OR, Dr. Hallet, kind of
Yeah.
initiated this whole new area of research for both of you. And I must say that it's kind of interesting for me to hear your thought process when you say, I've been watching my surgeon colleague and they've been operating for 9 hours and they've been doing this, and how could I help them? When I've just come away, earlier today from a coaching session with a surgeon. Their division kind of hired me and my partner, Linda Miller, who's a certified ergonomist and occupational therapist, to do sort of some group and then some one-on-one coaching. And one of the first things the surgeon said to me was, I don't always ask for the table to be moved or up or down in height or tilted so I can access my surgical field, because I feel like, how many times can I ask our poor anesthesia colleagues to do that? And I feel terrible asking them to keep doing this. So, this then brings me to kind of the next question that I have for you, which is also a follow-up to what you just said. Given what I've just stated about what the surgeon's viewpoint was today with me, how do you then, translate that to this concept of team ergonomics that you were talking about? And perhaps this is a good place for you to share, the data that you found in your own studies with Julie and others at the University of Toronto.
Sure, I think it's a great question because we didn't have the answer really to that, and that's what we were talking about. And if you ever speak to Julie, she's a champion of ergonomics and prolific researcher and innovator. So, I was speaking to her about it and said, what literature is there? And I said, from my knowledge translation background, I said, do we even know the problem in team ergonomics? Yes, we
Hmm.
know anecdotally. Our thoughts from looking at our own institution, the biggest gap in ergonomics we think is often because it's treated as an individual issue, like
Hmm.
posture or a team, rather than a systems problem or a team problem. There's
Hmm.
also, we think, a lack of formal education around it. So clinicians would really rely on habit rather than structured best practices. And finally, I think it's rarely integrated into workflows, which makes it inconsistent and easy to overlook. But that's all our personal anecdotal lived experiences, right? So I was speaking to Julie, he said, can we create an initiative to figure out what the problem is and how to potentially address that problem? So we came up with like a something called the SOAR study, which is a simulation for operating room ergonomics. And we made it like a two-phase study. So phase one was about gathering info. So basically, what is the problem? And we want to gather from all sources, take a 360 look. So we did your basic questionnaires that were sent out to all team members in the OR. And then we also did live observations with human factor specialists, chiropractors, physiotherapists that actually came into our ORs and watched live surgeries and took notes on best practices in ergonomics that are happening in the ORs already versus things we can improve on or challenges. And they looked at different types of surgeries and they were making notes and coming up with themes. And then after that, we also did qualitative interviews with the team members. So we kind of looked at it from all different ways and we came from
Right.
different approaches. And in line with that data that I told you about from that were like, they say 40 to 90% of the prevalence of work-related musculoskeletal injuries, we found that one, about 70% respondents reported pain while
Hmm.
operating, with the most common location being, yes, lumbar and cervical region. Now, is that a surprise? No, but it is a large number. Say
Right.
about 60% of participants reported that pain impacted their life outside of work. Almost
Wow.
half the participants, 48%, stated that pain affected their work.
Mm.
And then we're like, okay, so this is a huge problem. Like, when
Right.
we quote numbers in medicine to our patients, if we said anything higher than like 1%, that's a high risk for something. And here we
Right.
are, 70% are in pain, 60% are having pain outside of work, 50% are saying that it's affecting our work in general. So we have, in essence, if I take the leap, we have inefficient teams right now due to pain and cognitive overload. So we said,
Yeah.
well, what do you know about, and the next question is, what do you know about ergonomics in terms of education? And 76% of participants reported they had no prior ergonomics training.
Yeah.
Only 5% reported they had received any type of ergonomics training in their medical school.
Hmm.
8% received it in their residency. And only 1.9% received training from any expert consultation from someone like yourself. And so I was like, okay, well, that's not surprising, but that is still a major problem. Now we have data that we can present to to leadership and to people who
Hmm.
make decisions.
Right.
Then from the
Stakeholders.
exactly
And,
right. So
and purse holders, purse stakeholders.
exactly budget, the
Yes.
wallets and the decision makers and the
Yeah.
stakeholders. But on top of that, we wanted to kind of give them kind of a wake up call. So we in the qualitative interview said okay, what barriers do we have for ergonomic challenges? Do you think? And they came out with
Hmm.
two categories: personal or organizational.
Hmm.
Personal was there's a lack of knowledge, so a lack of education, so that came out. There was
Hmm.
also a fear of speaking up. Like they said that if I come speak up and say I'm in pain or this is wrong, then it's not gonna be either taken in or it's not gonna be a safe space, or
Hmm.
I'm gonna feel vulnerable and no one's gonna listen to me. And
Right.
then there was organizational, so a lack of time to
Mm-hmm.
address ergonomic issues that are in the OR or in the rapid pace environment, lack of
Mm-hmm.
space. The equipment purchases are not done with ergonomics in mind. It's usually cost related, right?
Hmm.
And there's honestly a lack of leadership and guidelines and protocols in place that have ergonomics explicitly stay embedded within them. So those were the themes that
Mm-hmm.
actually came out from the qualitative interviews. So now we have all of this kind of put together.
Mm-hmm.
Um, so while we see that ergonomics train is when we think about ergonomics, it's kind of thinking in isolation as a single role. But we
Hmm.
said that this is a team issue, and we have all these cognitive barriers, physical barriers, system and organizational barriers, and then within ourselves the personal barriers. And how do we think the next step for phase two was, all right, getting this data and getting these themes, how are we going to address it? Now,
Right.
how are we going to address it from the organizational perspective? Is that what this is from a personal perspective and a team perspective?
Mm-hmm.
So we're in the middle of working on that right now. And
Mm-hmm.
part of that is creating simulation scenarios to
I
teach
see.
team ergonomics, both the cognitive aspect in terms of creating safe spaces and speaking up using different communication techniques that have been validated in other areas, as well as
Mm-hmm.
the physical ergonomics, where the things that you usually see in the literature of how we can help each other with positioning, movement, setup, like you're saying, bed height, equipment, that type of thing. And then taking this data and how are we going to present this data to the stakeholders so we can embed them into our workflow,
Yeah.
embed them into one of accreditation practices in the hospital where our colleagues are actually being looked at in terms of what is the rate of sickness, what rate of illness due to ergonomics, what rate of pain, and embed that into accreditation. So that would be honestly one of the goals, and as well as making protocols and processes such as the checklist that are embedded into our daily workflow so it becomes
Right.
a culture change rather than just a one-off thing.
Wow. Fahad, thank you for taking the time to walk us through the work that you and Julie did along with your teams to define the problem, and use both kind of qualitative and quantitative data to then, as you said, figure out what potential solutions can be, try them out in the sim lab, which you're currently in the process of doing, and then hopefully be able to figure out a way to implement them so that they become hardwired into our systems and workflows, right? Because that's a huge
Yeah.
barrier I find, whenever we're doing workshops or coaching, that piece of the implementation often becomes a huge barrier, as you found in your surveys, because we can teach individuals what to do, but it has to fit into the workflow. No one wants to be seen as a diva, right? I've heard
Yeah.
that from many surgeons. Like, I don't want to be seen as a complainer. And I can certainly see nurses or anesthesiologists having the same sentiments. So creating that psychological safety is equally important. And this is where when we say ergonomics has three parts, as you've heard me and others say in various episode listeners, there's the physical ergonomics, but then there is this whole cognitive ergonomics piece, right? How we work. That's where the psychological safety would come in as well. And then there's this organizational ergonomics. So it's nice that you've addressed or are attempting to address all of these through the work that you're doing. I realize that this work, the simulation work, is still ongoing, but I wonder if you have any insights that you've seen so far that you might be willing to share on the podcast.
In terms of the work that we're, in terms of intervention solution. So what
Right.
we're,
In this, like, how did this translate, into the sim
yeah,
lab, like the interventions that you're trying to implement?
of course, no problem. Happy to share that. And as an aside, when you say diva, one of our qualitative comments actually
Uh-huh.
came out where one of the OR team members referred to a surgeon as a diva for using those fatigue mats.
Oh, I know. That's why I
Right?
have heard.
Like,
Let me fill you in, Fahad. I recently learned new terminology. So I used to say they're often referred to as princess pads, right? Both by
yeah.
practitioners and the people who kind of bring the pads to us, right? But then I've heard, as you said, so and so is a diva for asking that, or what is it, high maintenance? I've heard
High
that
maintenance,
term
yeah.
thrown around. And most recently, I was corrected by someone because they said I needed to use gender neutral language. I shouldn't say princess pads. And I said, sure, what would you prefer I use? And I was told, well, actually, they're sissy pads. So there you
What?
go.
Really?
So,
No. That sounds worse to me,
so
but
so there is that culture piece for you.
yeah.
So go ahead. Go ahead.
And those are the culture barriers that we're dealing with, right?
Yeah.
You know?
And we will be right back after this short message. If you're a surgeon or proceduralist finishing your OR days with neck pain, back pain, hand symptoms, or just feeling physically drained, I want you to know something important. These problems may be common, but they're not inevitable. Most of us were trained how to operate, but we were never taught how to operate for decades without accumulating preventable strain or reducing the risk for a career-ending injury. That's why I created the Surgeon and Proceduralist Career Longevity Program, a fully virtual hybrid program that combines small group learning with individualized ergonomic analyses using your own work videos, AI motion capture software, and surgeon-specific recommendations. Just to be clear, this isn't generic ergonomic advice. It's a personalized approach designed around your body, your specialty, and how you actually do your work. If you want to keep operating at a high level without sacrificing your body in the process, sorry, just edit out this last section. I'm going to record it again. If you want to keep performing at a high level without sacrificing your body in the process, or are looking to return to the OR after recovering from a minor or major injury, reach out to me at geeta@surgicalergonomics.com to learn more. And now back to the episode.
So the first step we did was we started making pilot scenarios. The goal is to make a simulation ergonomics toolkit, one that we can package and send out to all our colleagues anywhere
Mhm,
and teams anywhere in the world, really. And it doesn't not going to require too much effort or even being in a physical sim center, right? So
mhm,
the first thing already started piloting was scenarios to look at the cognitive or psychological safety aspect of ergonomics. So we started creating scenarios using basically a two challenge rule and as practicing escalation using what we call the CUS framework, right? Where you could say something like, I am concerned, I am uncomfortable, this is a safety issue. So the
mhm,
ergonomics scenario that we're creating now and that we have already started piloting are where, there's common scenarios, prone positioning, setting
mhm,
laparoscopic towers, introp retractors, that type of thing. And we
mhm,
trying to make it look like, and you're taking part in roles as teams,
mhm,
as a neurosurgeon, anesthesia, And in your roles, we have one scripted scenario, scripted role, and then two loosely scripted roles, right? Where first thinking, if in a prone positioning patient, say, one of the scenarios is where they're already prone, the anesthesiologist is in a rush, and I've disconnected the ventilator. We have to flip the lines already. Hurry up! But the last person is not there yet to help with the flip.
Mm-hmm.
So between the surgeon and the nursing, and the nursing is overwhelmed with this patient.
Mm-hmm.
We want someone to, and we're through the sim scenario, they're practicing having them speak up, saying, I'm concerned. We need that one more person. I'm not able to receive the patient, and some of these scripted scenarios which we have multiple scenarios and they'll escalate in terms of learning. I might, as I see those in one of the scenarios, I might dismiss them. I say, no, I need to go, hurry up, let's go, because the patient is not being ventilated right now. And then maybe the surgeon can speak up and say, I am uncomfortable, right, with moving this because I think this is what's going to happen. From A to
Right.
B is going to lead to B. And then or you can use one of the words where I think this is a safety issue. Now, the question is, you can once we give people those skills, those buzzwords and phrases to speak up, sometimes
Mm-hmm.
in real life that might not help. So the question from a system thing is, what happens next, right?
Mm-hmm.
So this is where you work in if the two-step escalation, if nothing is changed and we have to go through that in that acute situation, nothing's changed, we have to put in processes where this is automatically escalated so that
Mm-hmm.
this is a reflection or a talking point afterwards, and things can change. Now, we're not saying you're going to report them to their chief, but there
Mm-hmm.
could be a debrief at the end, automatic debrief at the end. There's a two challenge here, and it didn't change. We have to talk about why this happened, why, and what to do next, right?
I
And
see.
that's going to look different for everyone, but this is something that we are advocating for when you come to your specific center. Now, people
Mm-hmm.
people have local incident reports. They have like system-wide incident reporting. Now, does it and how high do you want to get and how big of an issue do you want to make this? Sometimes you don't want to, but there has to be something that once the escalation has happened and it didn't change, what do we do next, right? And that's kind of the psychological thing. And the next thing we're also working into these scenarios is ergonomic checklists, right?
Mm-hmm. Mm-hmm.
So I get both different types of reactions where when I say ergonomic checklist or ergonomic timeout, right?
Mm-hmm.
People kind of groan and say another checklist,
Right.
or they say, okay. And the point of an ergonomic checklist, in which we're still working on a study right now to figure out what, or a Delphi protocol, what actually should be an ergonomic checklist versus what and when should it be implemented during what
Mm-hmm.
stage of the procedure. But we're thinking of this is a real way to make it psychologically safe, another way of people being able to speak up. So
Right.
if it starts off with basic introductions. My name is Fahad. I'm the anesthesiologist. I'm so and so. I'm the surgeon. I'm so and so the nurse. I'm so and so. I'm the circulating nurse. And making that open and upfront statement that we are cognitive ergonomics. If there's an issue, please, this is a safe space. Please feel free to speak up.
Mm-hmm.
Having said that, we know there are timings where speaking up during a tense situation in the OR, if there's like massive hemorrhage or there's a very tense situation where we're clipping an aneurysm in the brain where I just want quiet, that's probably not the best time, right? And you probably not the best time for me to be moving the table up and down because I think you're in having trouble, right? Especially when you're trying to clip an aneurysm. But those are this during this ergonomics timeout, you could talk about identifying these risks. My name is
Right.
Fahad. This is where I am appreciative of ergonomics. Please speak up. But here are potential ergonomic risks periods during this scenario. When I'm clipping the aneurysm, and I'm making this dissection of the liver, right? But other times, please speak up. Or here's the time we're going to have breaks. And as for equipment, this is the type of equipment that helps me, that will help you. Each side,
Mm-hmm.
and here's how we're going to cable the wires. And here's maybe how you can assist me when it comes to ergonomics. Now,
Right.
is that something that we speak of for the patient sleep? Potentially not. Maybe right before the first incision or right after the first incision, that type of thing. And
Mm-hmm.
I personally think this is anecdotal. We're still working on it, that the ergonomics timer can be fluid as to when it happens, but there
Mm-hmm.
has to be certain specific components, which we're working on, which exactly those components are. But the ones I spoke to you right now about are, I think, the basic principles.
Mm-hmm.
So I think that makes it a little more psychological. So right now we're working those into these simulation scenarios. And another thing that we're going to do is using virtual reality, where we start filming VR 360 videos
Mm-hmm.
as in a way to help our team members to walk in another team member's shoes. So I, as an anesthesiologist, can put on a VR headset and see an immersive first person perspective of the nurse in the room and how she's
Right.
setting up for a spine surgery and the different steps. So I know the critical points, what he or she's going through, what when he's flipping or when she's flipping, and feel the tension in first person in an immersive perspective from their perspective so that I'm aware of when I go back to real life, I know what their flow is and how they are in the first person so I can
Hmm.
potentially help. So obviously with these 360 videos we'll have ergonomic pitfalls built in and
Sure.
best practices and they can walk in and it'll be highlights of different cases, not like full cases obviously. That'll be like 5, 10 minutes long and same way the surgeon could be in my perspective, I could be in the surgeon's perspective. And that's the power of virtual reality, right? You can really immerse them in a different world or a different person's body, right?
Right.
And increase empathy and understanding. So
Yeah.
that's the another form. So when we say simulation for operating room ergonomics, it was not just mannequin simulation, it's in situ simulation, it's mannequin-based simulation, it's also virtual simulation, and also teaching materials.
Yeah.
So and that's kind of the process. We're kind of bouncing the idea back and forth of making specific VR simulations directed towards the decision makers and stakeholders, and from the patient perspective as well. And maybe that will, you know, because we've done things in the past where we have healthcare providers in the hospital putting over your headsets so they feel what it feels like for a patient to be delirious. So maybe senior leadership can feel what it feels like to be injured and on the job, moving slowly,
Wow.
trying to move the patient, flip the patient, and
Right.
be on the front lines again, right? So we're trying to figure out how best to do that and to do it in a way that is appreciated.
Wow. Thank you so much for sharing, this work in progress. And I must commend, you, Julie, and your teams for taking on this work. I think when it's completed, it will have a lot to add and help, sort of as we referred to earlier, kind of hardwire ergonomics into our workflows and conversations. Like you said, it's kind of there but not there. It's hidden, behind our kind of closed door
Yeah.
conversations. So I'm really, really excited about this work that you're doing, and I can't wait to see, how it all plays out. I was thinking about something as you were mentioning the virtual reality piece, walking in a team member's shoes. I must admit, I got much more attuned to the ergonomic demands of our nurses and scrub techs and our anesthesiologists when I started delving into ergonomics for surgeons, driven by my own symptoms. I'm going to share an example. Sometimes, you're sort of standing in the OR and you're waiting for your anesthesia colleagues to do what they need to do so you can get to your part of the procedure. I decided that I would either start using that time to stretch myself, and get ready sort of in to be in the space for the surgery. But then I also started noticing that maybe the anesthesia resident was trying to do their job, either putting in a line or maybe doing a fiber optic intubation without being at the right height. And so I would quickly slip kind of a step underneath them or suggest a step, or where their monitor for the video scope is not directly in front of them, kind of say, is it okay if I move it right in front of you? I think you'll have a better time of this. So it's amazing just that walking in that other person's shoe, you realize what all of us are working, what conditions all of us are working under, and how we can truly help each other, right?
Yeah.
So, yeah, so that brings me to kind of this other question for you. Through these entire scenarios and simulations, you put the onus kind of, or sorry, you put the spotlight, I should say, on the surgeon. I want to know, from all the things that you've been doing and learning, how can us surgeons and surgical trainees help our anesthesia colleagues, while we await the studies to come out? How can we help advance team ergonomics, in a practical sense based on what you've learned so far?
The scenarios we're making and everything, there's like some for surgeons, some for anesthesia, some for nursing, and I think
Hmm.
I think kind of what you were just saying too, there's the actual granular things where you actually stand up and say, I can see that there's an issue here. Here, take a step
Yeah.
stool. Let's move the
Mhm.
ultrasound screen in front of you. But really, I think the discussion of, hey, I want to help, and this is not for me to, same way for me towards nursing or surgery is not for us
Right,
to, I'm not trying to speed you up or anything. I'm just trying to help you, right? This is a
right.
safe space and we're trying to
Ah,
help each other, right? Because I think it builds camaraderie and team safety where I can see, sometimes when I am trying to do a complex patient that needs lines and difficult intubations and things of that sort, and the surgical team just or the nursing team, surgical team kind of steps out of the OR thinking, I want to step out because I don't think I
it's
don't want to
not
be
my part of
pressuring
the
you,
procedure.
yeah,
Yeah.
or I don't want to be pressuring you because sometimes when you have someone standing over you looking at you, you feel pressure and they're like, maybe I'm helping you, right?
Hmm.
And then you kind of like, okay, I'm going alone. I'm trying to move this. Let's do this. Let's hurry up and get this case going. But sometimes, if you were to stand up and say, "Later, let me help you," let's put it feels like okay, we're working together, right? The same way I'm going to work with you afterwards. So I think that's one of the first things is that making it breaking that barrier of keeping that communication and that work and that safety across but all the members in the OR really makes a difference, right? And then yes, there are like physical things where we can move things around and and then but also check in with each other, right? Check in with each other in terms of I've obviously been at my hospital for a while now, so they know me well. But there are times when they know if I'm like underneath the drapes trying to move things around, bending over, something's happening. So they'll stop and say, Fahad, are you okay? Is there anything I can help you with? Should I step away so it's easier for you to come in? Like if a line's not working and I'm trying to get on the wrist but not bother the surgeon, they could be like, can I step away so you don't hurt yourself? And I think that those type of recognition for and comfort level with each other makes a big difference. So
Mm.
that's how we can be helped in there, and same way we can help you, like just kind of checking in with each other. Where okay, everything okay from the anesthesia side, everything okay from surgery, everything from the nursing side, and I think these are just basic principles where we communicate that this is a safe space. I'm going to stick around, but I'm here to help you. Or it's 2 hours into the procedure, everyone going okay, anesthesia okay, is everything okay from your end? We've put the patient really head down right now. Is the patient from a positioning perspective okay? Can you still have access? And now, and Julie's actually done a lot of team publications where how better the more the teams work together, the better they are, and it kind of makes so we're trying to bring new teams and get more comfort really quickly to the point where they're working a lot together. So in terms of ergonomics, it's the same thing, right? So if you're
Right.
checking with each other, having those discussions. So I think that's really like, we could go into the weeds of, don't put your monitors right above my head when I'm trying to intubate or that type of thing, right? But that's going to change with each position, each patient, each procedure,
Correct.
each
Yeah.
right. But it's more we're gonna learn that as we check in with each other, as we communicate that we're here to help each other. And do you need a break, or did any student in nursing, do you need a break? Do we all want to take a stretching break? Is our micro break time right now? Is there anything that we can do to make this is a complex part of the procedure before we start? Is there anything we can do to make things easier? What is the basic the approach that we can do from ergonomics perspective, whether it's cognitive or not? Should we lower the music a little bit? Is my SAT probe beeping too high right now, or I
Yeah.
can't hear it? Can we lower the music a little bit? That type of thing. And those check-ins at different times periods of the surgery can really be helpful, right?
Yeah.
And
I
I think
love
that communication.
Yeah, I love this approach. And, for our listeners, I'll also let you know that, as Fahad has pointed out, some of this work is published, and I'll make sure to include the links to these publications in the show notes. And if people are interested in learning more, do check out the podcast episode I did last year, so several months ago, with Dr. Julie Hallet from the surgeon's perspective. And if it's okay with you, Dr. Alam, I will include your contact information if
Sure, no problem.
people want to reach out to you to sort of learn more about the work you're doing and how they might be able to apply it at their institutions.
Yeah, that'd be great. No problem. Happy to chat. I love chatting about the stuff. You guys have put the, you guys have definitely made it exciting.
All right, well, great. So, with that, I think we're almost to the end of our time. And so, Fahad, again, thank you very much for squeezing me in at the end of your week and at the end of a long Friday evening for you to spend time with me to record this episode and share your thoughts and the wonderful work that you've been doing. I look forward to kind of seeing what comes of the checklist Delphi project with pertaining to the ergonomics checklist. I did fill out the questionnaires that came my way. So again, thank you
Thank
for
you.
all the work that you're doing and for being here.
Well, thanks for having me. It was a pleasure. It was quite enjoyable.
Please remember to subscribe to the podcast and follow us on social media, Instagram, X, Facebook, and LinkedIn. We love feedback, so please reach out to us for topics, ideas, speakers, or if you ever want to be a guest on the show. Thank you for listening.